Good afternoon, everybody, and thank you, Dr. Sood, for making me a part of your instruction course. And I'm going to take you through correlating structural change in the optic nerve with functional loss on perimetry. So if you have a look at that, it is actually one of my favorite slides because it is so self-explanatory. The colors actually tell you which area in the disc should give you a clue to what you should look on the field, or if you see that area in the field, you should look into the disc and correlate the two. So the colors match each other, as you see out here. If you're looking at this area, you match it with this area out here. Similarly, if you're looking at this area, the deep blue, you match it with this area out here. That's how you do it, and this is a very precise chart because it gives you totally degree-wise what to look for. And that's a broader aspect of the whole thing, which is also very self-explanatory. So if you have a look at this, actually, I got these pictures here because if you look at this, that's the superior arcuate RNFL sector defect, which will go with the inferior arcuate thing out here. And if you look on this, then these are the areas which are affected by this temporal to superior. That's exactly how it is. That's exactly how it, the whole thing functions. So if you're seeing the disc, you should, by seeing the disc, be sure what you're going to expect on the field. So uniform enlargement of the cup, there you see. Can you delineate the cup and the disc? There's an absolute uniform enlargement, and in this kind of a picture, if you keep a drawn picture which you have seen, so next time when the patient comes on a follow-up, you can actually see your picture and get back your previous image that what you had actually seen when there is this kind of an uniform enlargement of the cup. These are the areas which show what we are interested here is the beta zone of peripapillary atrophy, and you see that the beta zones are shown by these white arrows that you see out here. That's the beta zone. That's what we're interested in. Larger beta zone is actually a sign of developing glaucoma. So it's a pathognomonic sign that the patient would progress. These are bearing of the vessels. These are very typical defects as well. The arrows, they are showing you the hemorrhage and the venous vessel, and there you have the bearing of the vessel out there that you see. Okay, Drance hemorrhage. Drance is nothing but the name of the person who named it. So if you have a look at this, if you see that hemorrhage out there with the arrow, this has been picked up by the angio-OCT, and you see a rim loss out here that you see because of that hemorrhage, and you see the visual field, and you have out there corresponding to that a developing superior arcuate defect. Next we come to an inferior notch, which is absolutely pathognomonic. If you see an inferior notch in your patient, you must absolutely take care of that patient well, because an inferior notch would definitely give you a superior arcuate defect on the visual field, and you need to actually follow up that patient well. Similarly, early inferior notch would give you, say, a paracentral defect, which would maybe later on go on to a superior arcuate defect. So an early inferior notch needs to be followed up as well. That's a bipolar notch. If you have a bipolar notch, as you see in this photograph out here, you can expect actually a biarcuate scotoma on the Humphrey visual field. That's a superior notch. There's a superior notch out there, and that would typically, due to anatomical distribution, give you an inferior arcuate defect. So what happens sometimes is that we get confused because we see something on the field at the slit, on the disc at the slit lamp, and then when you order for a field, when the field comes, you see that it's completely different. So the factors that you must consider if there is a disparity between the disc that you've seen and the field are dilate the pupils, because if the pupil is too constricted, you might get a field which shows a glaucomatous defect which is not matching your disc. A proper refractive error correction must be done. Correct the age of the patient if it's not given there, because Humphrey has this protocol of matching it to the age. And then if there is ptosis, make sure that your technician has strapped the lid, and then postpone the test if you see that the parameters are not right and your patient is tired. Next we move on to this. This is actually, the diagrams are small out there. So this is where you have the hemorrhage, and then you have the follow-up of this hemorrhage, and when you see them on the visual field, and this is what the visual field will actually show you the progression of the patient. So this is a diagnostic factor on the visual field when you see progression on your disc charting. This is a picture actually of the forum. They have this forum now where you can have your RNFL and your disc pictures and your Humphrey visual field, all of them on the same screen, and you can actually compare them well. This not that I've put these pictures together. This is the screen that you can actually see on your laptop or your desktop that is attached to the forum, and you would actually see these all at a glance, and this makes things pretty simple, you know, to compare and see. Next we have, Dr. Sood has actually covered this very well, but even then, just to mention a line about it, is that when you see a myopic disc, please see it with caution, because myopic disc can actually produce false visual fields, and your interpretation of the cup disc ratio also might differ. So, and if you're not very sure about it, you can do an IO and be sure that it is a myopic disc, and that is what's happening. And next is the inferior coloboma, which has produced that defect, because that's not a glaucomatous disc at all. Next you have these, where if you followed up a patient with this kind of a disc, say inferior hemorrhage and then an inferior notch, and then when you see it on the Humphrey visual field, there's a superior arcuate defect, and then a superior arcuate defect extending nasally and going, so they are almost sure of your diagnosis. Dr. Sood had asked us all actually to show how we actually document our discs in our day-to-day clinics. So that's actually a picture from the file that I use to see my patients at office. These things are printed on my file, so what I do is that I generally do IOP, this reading comes, they do it before they send the patient to me, the CCT. I do the gonioscopy. There was nothing much important in the gonioscopy here, but this is the kind of fundus that I draw, where I put the vessels, bayoneting vessels out here. I've put these lines out here for me, that when the patient comes back after 3 or 6 months, I know that the cup was pretty deep. Comparatively, on this side, the cup was not deep at all. It was shallow, because there's not very much of a difference between the size of the two cups, but then there was definitely a big difference between the lamina cribrosa of this and the lamina cribrosa of that. So that's the reason, I drew it like that so that I remember it. I drew the beta zone prominent in this, but absolutely nothing in that, and that's how I actually document my photographs. And thank you for your attention.